Hello, everyone. I'm Michael McNett with Weedy, and welcome to a special spotlight, automated prior authorization in real time for payers and providers, presented by Edifecs. It's my pleasure to introduce Maxim Abramsky with Edifecs.
Thank you, Michael. Let me share our content for today. Let me know if you can see it.
Perfect.
So today we're gonna do a bit of a repeat of what we've done during the in-person presentation at Weedy, except we added some additional flavor and some extra observations that we've collected over time. So we'll begin with our introduction, who is Edifecs, what we do, and why prior authorization is the main focus for us today. Then we will move into the current state of the prior authorization. What is the problem and what people do today? Many of you already know this, but some of you may not know the other side of the story. If you are the representative of a payer, you may not know what's happening at the provider side that well, and vice versa. Then we'll segue into the challenges. What are the industry expectations? What people look for in terms of the prior authorization implementation, and what changes drive today's implementation? What happened in the industry today that helps us solving the prior authorization. And then we'll show you what we do from the prior authorization perspective at a high level. We'll explain our approach and how we implement that. And then we'll conclude with some high-level findings and the next steps. So with that, I'll start the presentation with the introduction. Edifecs is a healthcare IT company. We are a technology company. We are in business for more than 26 years. And throughout these years, we've been building all kinds of solutions for our customers, primarily peer customers and also provider customers. So throughout the history, we pretty much implemented all lines of businesses for peers, including enrollment, encounters, risk adjustment, all of the compliance mandates. Edifecs is a host for certain certification testing tools for CMS, CAQH, and other industry. And with a recent acquisition of Telex and Health Fidelity, those are two companies in risk adjustment business, we've got a lot of new technologies and very good provider footprint. So by now, Edifecs has a lot of exposure into almost every health plan in the nation and most of the largest providers. That kind of drove us towards implementing the prior authorization solution and bringing up this bridge between providers and peers. So today we're going to talk about Edifecs prior authorization solution, why we decided to build that solution and why it is important for you, whether you are provider or peer or a vendor, because this solution, as you see, cannot be implemented in silos. It is not possible, and it was proven by many failed implementations. It's not possible to just do this for payers alone or by payers alone. It has to be built in tandem with providers and peers and vendors, EMR vendors, integration vendors, technology vendors like ourselves. So with that, I'll go into the current state of the prior authorization. So essentially, what is happening today? Today, prior authorization, and this should be no surprise to anyone, is a very manual process. We can probably compare this to pre-HIPAA age when claims were submitted on paper. If you're not that deep into the prior authorization, you may be surprised, but about 70% of prior authorizations are submitted today via the fax, meaning somebody prints out the patient chart and the forms and send them over the fax to a payer for review. The process consists of multiple typical steps. First is the member eligibility, just to verify that member is eligible for a certain service. And then there is a check for the medical necessity. Just these two steps typically account for about 30% of incorrectly submitted prior authorizations, which means provider not knowing that certain procedure does not require prior authorization or certain drug, they submit the application to a plan anyway, which means first the patient's treatment gets delayed because the prior authorization is sitting in the queue to be validated. And since it is paper, some human has to take a look at that, especially if there are some processes like if this is a group order or something that involves multiple procedures that would require multiple people at the back end of the plan to review that. So that's a lot of time on both provider and payer end. And that starts accumulating the cost, which you can see down here, for the prior authorization. So beyond just the fact that this is a incorrect prior authorization submission, there is a very high associated cost to that. The next step within the back end of the peer, the submission, somebody would have to take the submission and manually enter this into the utilization management system, if such system exists, because some of the peers, we talked to some of peers during the discovery phase, and several peers said that they don't have any kind of tracking for the utilization management review. They use things like Zoom chat or Excel spreadsheets hosted on the network. And those old-fashioned tools are used to review such very delicate process as the prior authorization. So manual submissions, manual reviews by clinical staff. As soon as you submit the prior authorization, typically somebody on the back end of the plan with relevant experience in the domain has to review this. All that definitely increases the cost of the prior authorization. Now the cost is getting increased on the payer side because payer has to hire a lot of people to do those reviews, making the decisions. And in some cases, if there are escalations for critical procedures or procedures beyond the capabilities of the review person, they may escalate to somebody like medical director, which even further increases the cost of the prior authorization. At the same time, if we look at the provider side, provider cannot perform treatment. So that means the patient can be in pain, they can wait for their treatment to be done, yet the submission is still in the queue. And it is not payer to blame for this, not provider. Providers will see some challenges that providers express, but basically it's a combination of lack of interoperability and lack of the good information flow between these two entities. Now, if we look at the number 6, which happens after the preliminary decision and potential escalations, often additional information is needed. The case has been submitted, there is some, let's say, knee replacement or some knee surgery, and the plan requires information about the prior lab results. That would delay things even further because the case, if the system is mature enough, the case will be sent back to provider without being declined for the additional information, or the case will be pended until provider calls into the plan, which happens most frequently. So the case will just be in the hanging state until provider calls in, and only then they will realize that additional information is needed. They would go back into the EMR system, print out some additional evidences, send them back. And then there is a peer-to-peer review at the end, and decision finally comes to provider. As you can see, there are so many steps in this process, and all of these steps are done manually. There are some variations like some portals which allow providers to submit the information. But as you can see in the next slide, the adoption of the portals is very low because nobody wants to retype the information that has been typed into the EMR system. So all that, in summary, leads to at least 15 days of delay for the regular procedures. Sometimes it can go as high as 30 days, and at least $14 per prior authorization submission. That is the cost that providers and peers have to pay to do the processing. And we talked to one plan last night, and they indicated that sometimes for the complex cases, they estimate the cost of the single prior authorization to be as high as $100 in case there is a group order with multiple services, and some of those services would require review by medical director. So this is a huge cost, especially considering the large national plan would receive approximately 2 million prior authorizations per year. So that becomes a very huge burden. Now, let's take a look into the statistics and what kind of constitutes the cost. On the left-hand side, you can see the chart, and you may find different variations of this. This came from our Edifecs interviews with our customers, and the average, which was reported, is 74% of submissions are done manually. And by manually, we really mean a combination of phone, fax, paper, emails, PDF, or direct data entry, because all those essentially are the same thing. I used this example when we did the presentation at WEDI in DC, that we talked to one peer, and they indicated they are 100% automated, like 100% electronic, sorry. When we dug deeper, they indicated that they have the system where provider can send an email and they can attach PDFs with their information, and therefore, since it's electronic mail, they are fully electronic. Of course, it doesn't change things much because somebody would have to sniff through these emails and extract the attachments, and then human would have to review the case, and it goes back to the previous diagram where the cost pretty much would be the same. The true electronic submission would be something that is well automated and goes from the EMR system straight into the PHIR's utilization management. Down at the bottom, there is a quote from the very good document by AMA, which is called Utilization Management Principles. And it outlines in the orange that faxes, the proprietary portals, phones, and all of the non-standard electronic forms like flat files or something of that form is not considered electronic transmissions. And that is true because by electronic in the prior authorization world, we really mean something that can be automated. And this is one of the reasons this presentation is dedicated to the automation, because only automation can really drive the cost down. And speaking of the cost, on the right-hand side, you can see the different costs that providers and peers currently experience from the prior authorization. For providers, on average, it's about 16 hours per week or about 80,000 per year per ordering physician, which goes to 10, again, different studies show different numbers, but it's about from $10 to $20 per submission. On the peer side, the cost is sometimes even higher because plans have to maintain very big staff of full-time employees who do just that, just the prior authorization reviews. And I'll show you in the subsequent slides that in a lot of cases these days, this creates a huge clinician attrition in the plan. People don't want to work on the routine tasks. They were trained to provide care and deliver care to their members, not doing the bureaucratic paperwork. So all that combined hopefully gives you a good picture of the current problem. So the process is very manual. Whatever tools exist today, like portals or proprietary solutions, don't work very well because there is a very little provider adoption of those tools. Providers don't want to go there and kind of type in the same information. Now, on this slide, you can see the typical layout of the provider and the peer ecosystem. On the peer side, let's start from the right-hand side. Peers typically have one of the three, or sometimes all of those. Some prior authorizations are done by carve-out vendors. So it can be something for radiology, like a full outsourcing. When providers are being told, go to this portal for radiology, to that portal for behavioral health, and that portal will service pharmacy. Everything else submit to us via the paper and fax. To providers, that creates a hell because they need to train people to use different portals. They need to train people to understand all of the different medical criteria that are used by those different vendors. And even for plans themselves, it creates some problems. It is very difficult to manage provider programs like, for example, gold cards. We'll talk about the upcoming legislations in a few slides. So this is already the reality in several states. And it is hard to manage that gold card programs or other performance-based programs because carve-out vendors rarely provide detailed statistics to the utilization management and the care management systems. And 74% is still manual. So whatever you do won't help because people would be sending you phone and faxes. On the provider side, definitely there is another problem. The treatment gets delayed. There is a problem with the revenue cycle. They cannot provide treatment. They cannot submit claim. They cannot get paid. So there is a revenue cycle disruption. And just in the recent months, several large hospital systems declared huge losses, net losses, due to various factors, including the declining economy. So anything that disrupts the revenue is critical to hospitals and, of course, to payers as well. So this high-level picture shows that despite multiple attempts to make things electronic, things were not made automated. And therefore, we have the vast majority of submissions done still via the phone and fax. So let's take a look at the challenges. So why that problem exists? What are the stopping factors from solving this problem? A few months ago, we've done like survey or interviews among our provider customers, and we asked that question: what is the main problem for you in terms of the prior authorization? The first answer was one of the main challenges is a lot of manual guidelines. Every plan has about 200 to 300 different guidelines for every situation. And those guidelines are specific often to the like CPT code or NDC code. And they define very well what needs to be submitted in order to be approved for a certain procedure. The problem is those medical guidelines are reviewed like every month, and sometimes many of them get reviewed and changed on a monthly basis, sometimes quarterly basis, but they keep changing. And if you put yourself in the shoes of provider, they have to work sometimes with 5 or 6 peers, and trying to follow up and keep up with all of those changes is nearly impossible. So what they do, they give up and they say, we'll just hit the print button, we'll print out the entire chart and we'll send it to you pair. You deal with it, whatever you can do. This is kind of an easy choice, but it comes with a price. As we've seen on the first slide, the cost of that decision is very high for both providers and the payers. But nonetheless, this is a very time-consuming process, the medical guidelines and review. The next challenge was the communication. Right now, there is no well-established communication between the EMR systems and the payers. By communication, we mean vendor-agnostic communication, standardized, non-proprietary. So there is no, even if providers wanted to submit something electronically, there are no easy means for them to do that. And therefore, they opt out to phone and fax. In some cases, we know that payers just require those providers under their contract to go into the portal, which is fine for the plan because they get like a shortcut and get the information from the portal. But it's not helping providers because they have to spend now even more time submitting things into the portal. And again, what they do is they scan everything and they create as many attachments as they can because they don't want to end up with the request for additional information after 2 weeks of review. So that communication currently is broken, and the care delivery is disrupted. And then, of course, the timing. Approval take long time. If approval took like few minutes or few hours, probably nobody would argue that it's needed. But right now, it can go as high as 30 days. And I myself was in this situation just recently, so I can tell it from firsthand experience that even simple procedure required 4 weeks to get the prior authorization. And to be frank, I changed my provider because my belief was my provider, I cannot change my peer or it will be too much for this obstacle. But I, as member, I'm making the decision to change my healthcare vendor, healthcare provider because of this problem. And as I will talk about this later in this presentation, we also talked to individual independent brokers, and they mentioned that speed of the prior authorization today becomes one of the factors they use to recommend this or other plan to their customers. So it is no longer just a technical thing. It is no longer just a technical problem. This is a business challenge. And those who do not automate the prior authorization soon may face the loss of business in the near future. So that was the problem, why it exists and what are the roots of the problem. Now let's talk a little bit about what the industry expects from the prior authorization solution. What is the expectation? How that solution should look like, what problems it should solve. First and foremost is obviously compliance. Every organization needs to be in compliance with either CMS if you're the peer, or ONC if you're on the like EMR or provider side. So compliance is definitely a factor. We'll talk about this in the next slide. These days, there is a very significant push from the legislation on both state and federal side in terms of reducing the SLAs, increasing the quality of the prior authorization, and forcing peers and providers to use the electronic prior authorization. And if you look deeper into this, what does the decrease of the SLA mean for a peer? If today you do the prior authorization within, say, 15 days, and the legislation says you have to do this within 7 days, that really means you either have to hire twice more people than you have today, which is probably already challenging for you even today, or you can use some technology that would help you adjusting your process to those SLAs. Definitely our choice or recommendation would be technology, but you need to consider those risks. The next is the quality. As I mentioned at the beginning, several plans, and I'm sure this is a problem for all plans, indicated that about 30% of the prior authorizations coming in are coming for the processes, for the procedures which do not require prior authorizations, which means 30% of the cost is pretty much a waste. So if those prior authorizations have been automatically checked at the front door, nobody would need to even look at those at the back end. So this is a very easy way to cut the cost by just properly check the eligibility of the prior auths. There are other aspects like the duplicate submissions. Often providers, by mistake, submitting the same authorization for the same code multiple times. Again, being the large organization, payers cannot easily control that when it's being submitted via the phone and fax. If there is no automation, if humans are involved, these types of problems are very difficult to catch. Also, the EDI, checking the EDI claim that is coming in after the treatment. Again, you have to check that the prior authorization was submitted and the prior authorization ID on the claim matches to what you have. In some cases, and that is sometimes pretty often, providers may get the prior authorization for a certain code, and then they can change this code to something very similar to that, but not exactly what was originally requested in the authorization. And that leads to claim denial, the adjudication system on the peer side, and a lot of back and forth processes on re-getting the kind of re-requesting the prior authorization. The next is, that was a critical feedback that we've received, provider friendliness. In order for the prior authorization system to really work, it needs to be friendly to providers. While we talked about a lot of costs on the peer side, but it is very important to indicate that if providers don't adopt this solution, the problem will still be there. No matter how fancy system, portal, or how well automated system you have on the back end of the peer, if providers keep calling you over the phone or sending 70% of faxes to your organization, you will still be in trouble. So the only way to solve this is to make the solution the way that is easy to use and friendly to providers. And since we're talking about providers, it definitely needs to be agnostic to the EMR vendors. It needs to be standard solution. It needs to be agnostic to the technology vendor. It doesn't have to be Edifecs. It doesn't have to be somebody else's solution in the EHR system. But all those solutions need to work the same way. They need to communicate using the same standard, and it should not be some vendor's proprietary solution. We know that some vendors in the past tried to implement pilots with providers and peer-to-peer organizations, but the fact they were using the proprietary technology led to the situation where those pilots stayed as pilots. They never went into the full-scale production use, and it never scaled across multiple providers in the same state. It stayed within the same combination or pair of provider and peer, and it was still in the POC. And the main reason for that is that proprietary technology, not using the open standards. And then last but not least is lowering the admin costs and turnover. At the bottom, you can see the actual feedback from the Glassdoor. I've hidden the actual name of the plan, but the feedback that was that you will be overworked and underpaid. That feedback indicated that there is a massive mandatory overtime. So people are forced to take overtime to catch up with a lot of manual submissions. And this leads to huge attrition of the clinical staff. People are leaving because this is not what they were trained to do. And this creates a lot of additional pressure beyond those limited SLAs. So that is another factor that you have to account for. The more automation you have, the better is the lifestyle of your people working for you. And many plans we talked to by now realize that. In fact, they brought this up saying, this is one of the challenges. Compliance is good. We want to automate things, but we want to take care of our people. We want to make sure people do what they like to do, and whatever can be done by the machine must be done by the machine. Those are 4 main items that we keep hearing from plans and providers from their own perspective. Let's talk a little bit about the legislation and what's happening in the industry. You all probably are very well aware of the upcoming CMS mandate, which was called 9123P for the burden reduction, which basically states that the SLAs need to be reduced, that peers need to implement something called DROS, which is the standard for exposing the medical guidelines in the electronic format, and that the peers need to do the electronic prior authorization and notifications for members via the patient API mechanism. So there are very good and relatively straightforward, if you just read them, requirements. But those requirements imply a lot of work on the peer side. We'll talk about this in a few minutes. Before we go there, I just want to emphasize that just in this year alone, the amount of the prior authorization legislation is much more than in multiple previous years combined. You can see that I think about 7 to 9 states either passed or have passed through like state senate, some legislations about the prior authorization. Texas, Pennsylvania have passed those legislations. Several states like California, Michigan, Nevada, and several more have them in process. You have most likely heard about the Improving Seniors' Timely Access to Care Act, which is reflecting on the Medicare Advantage plans. Again, same thing. Do things faster, do things in the electronic format, make the prior authorization faster. That creates a lot of burden on the payers. So essentially what the legislations do today is they're shifting the cost of the prior authorization from providers into the payers. So if previously prior authorization taking long time was the provider's problem because they could not provide treatment, now this is becoming payers' problem. And to make things even worse, in some states like Pennsylvania, the mandate actually says that there is an implied approval if the payer does not respond within certain SLA, which means if the payer is overwhelmed with the prior authorization submissions and they fail to reply back to provider can go ahead with the treatment because this prior authorization is deemed approved. This is huge because now this is no longer just a compliance requirement. This is the direct financial risk to the plan. If you do not comply to that, or if you do not make your solution faster and more automated, you will just carry a lot of additional costs. You will be paying for potential services which are not medically necessary or services which are overly expensive. So many payers realize this and they are taking proactive steps and researching what kind of solutions can be employed here to overcome those challenges. Let's take a look at some of the industry changes that happened in the recent couple years. First is AI and NLP. We keep talking about this from different perspectives, but I just want to emphasize that AI, the term artificial intelligence, have been, overused in the past 5 years by some vendors who made this kind of a bad word. But deep inside, the AI NLP can do a lot of really magnificent things. Things like analysis of the unstructured data. So today, Edifecs is using AI and NLP for things like risk adjustment, for prior authorization. One example can be a member comes or patient comes to a physician and he was discharged from the hospital, and all they get from the hospital is the PDF file with the discharge summary, which includes all of the medications, conditions, some lab tests which were done at the hospital. And typically what provider does, they just attach these into the EMR system. Now, when the prior authorization comes, it may indicate the certain tests, whether certain tests have been done to this patient, and if so, what are the results? Just having the PDF would not let you give an answer to this in the automated manner. But using AI and NLP, you can really break that down into the ICD codes, the HCPCS codes, some conditions, and that helps pre-populating the answer, helps the answer being richer and more accurate from the clinical perspective. So AI and NLP is no longer just a tool for geeks to play with. This is the real production item, real production tool for the industry to use. Then second is the evolution of different standards. Many of participants here are part of Da Vinci, and Da Vinci is doing a great job in standardizing the technology. Like I mentioned before, all of the proprietary custom implementations fail because there are so many providers, so many EMR vendors. It is nearly impossible to make a very good proprietary technology that would fit them all. Standards, on the other hand, is exactly the tool for that. As long as the industry complies to standards, there's a patient access API mandate, which was implemented in the past couple of years. We have several dozens of successful implementations, And there are multiple client applications which are connected to health plans where Edifecs provided the solution. And the only reason that became possible, and we don't even talk to those vendors, to those client application vendors, because we expose the standard interface. They're using the standard implementation. They don't need anything from us. They have all they need in the standard. So the beauty of the standard, and once it is used in the proper manner, is things become really interoperable. And I want to thank DaVinci for making this very good job in developing those standards. Prior authorization standard, which is broken down into the 3 sub-implementation guides: CRD, coverage requirements discovery, DTR for the requirements determination, and the PIS. Those are very mature standards, and this is what we use today in real life to do the prior authorization. And then definitely the legislation, we've talked about that in the previous slide, a lot of pressure and a lot of adjacent mandates which kind of help each other promote the same message. Let's do things faster, better by automation. Now, let me switch into what Edifecs does, how we do things, and what is that we do today, which we didn't do before. So just to recap, today's prior authorization is very manual. We talked about this. I just want to reiterate this because it's very critical. Things are done via the phone, fax. In the best case scenario, it would be the portal. Providers keep doing this, and they will keep doing that until this problem is solved. On the back end, unfortunately, there are many plans who have not very mature prior authorization or utilization management system, and they keep doing things in the manual way too. As I said, some keep using Excel spreadsheets, some keep using something very weird like chat or Teams or something else which is not really designed to accomplish this goal. That leads to a lot of errors, human errors, technical errors. So the way we look at this is we approach this from several angles. First and foremost, by having very large footprint with so many peers in the nation. First thing we do is we digitize the medical necessity guidelines. So essentially those lots of PDF documents, we take and we transform them into the electronic standard format. So we are using FHIR questionnaires to present the questions that need, or customized form that needs to be sent into provider. And while doing that, the form is presented in the EHR system. This is the fundamental shift from where things are today, because now providers don't need to guess. They don't need to guess whether prior auth is needed for this procedure, because we've already done this check and we came back with an answer. If the answer is positive, you have to do the prior authorization. Then we bring in the form. Many of you know that portals today are more or less generic. Like you have to choose whether you do radiology or oncology or something else, and you're presented with a very generic form, like indicate who is your patient, who is your provider, and now attach all of the things you think are necessary to help this prior authorization submission. So you have to kind of attach a lot of things. We change these by saying these are 10 different things that you need to answer in order to be approved for this specific code. And that determination is not done by us arbitrarily. We go into the medical guideline and it comes from the medical guideline. So if the medical guideline says the procedure is only approved for female 45 years and older, we have to ask for the gender, we have to ask for the age, and whatever else is needed for that specific code. So that takes a lot of guesswork from providers. Now, the next thing, if we just stopped at that, this would be kind of an enhanced version of the portal. And most likely providers wouldn't like it because they have to retype again, many more things. So to solve that, we are using the, again, we're using the standard called clinical quality language, CQL. And in fact, Edifecs, along with other organizations, we participate in the Da Vinci-driven group, which is dedicated to secure loan. So we are maturing this standard. We are interacting to see how we can make this better. But the key point of this is we interrogate the EMR system and we extract the information from the EMR system to fill out that form. So now, being a provider, first, I see the form that needs to be submitted for my particular order. It's not a generic form, it's a very specific form. Second, all of the information that exists in the EMR already has been pulled out and pre-populated in the form. So I don't need to retype this. This is one of the challenges and one of the obstacles in adoption of the portals. It is all done for me. And Edifecs is using AI and NLP technology to also go and look into the unstructured data. So this is kind of an extension to the standard process. We can go just one extra mile and look at those PDF files which were attached into the EMR system, or it could be the progress notes. We work with one of our partners who is in business of doing the voice recognition. So in some cases, provider just narrates the progress notes. They transform this into the text, and we transform this into the actionable codes. We can break this into like ICD codes, HCPCS codes, conditions, vital signs, things like that. All that helps automating the prior authorization submission. And that, if we go back to one of my previous slides where it said, solution has to be provider friendly. This is our contribution to the provider friendliness. We try this solution to be as friendly as possible. But eventually things will go out into the payer, and some payers, as I said, don't have very mature utilization management workflow. We provide the solution for that. Our goal is not to replace the solutions which exist in the market. In fact, we partner with several vendors and we connect to them via the API. Our goal is to fill that gap that exists between prior authorization submission, electronic submission, and the review. We support things like the automated review, so that, again, we're using the secure language to do the automated rules. That takes out the burden of the duplicate submissions, of the submissions that don't require prior authorization, all those wasteful prior authorization submissions which consume a lot of time and effort from the payers team. So that is the piece that we handle. And when time comes for the decision or request for additional information, the process just repeats. We go back into the EHR, we indicate provider about this submission, and we're using definitely Smart on FHIR application in the EHR, which is supported by Apex Ordinary, Allscripts, Athena Health, and many more EHR systems. And all that kind of stays within the same integrated process. So no longer providers need to leave their comfortable place of work. They don't need to retype the information, and payers have a very good data that is coming in. That data is tailored to that specific medical guideline, and it is much easier to review. Now, if we look at this from the step-by-step perspective, the process starts with what we call a policy management. This is the place where we provide the tool set for peers to step in and declare which policies they want to automate. Edifecs is using, again, NLP technology to go from the PDF files, or in some cases, providers just use the Microsoft Word to create their medical policies. So we can take that human language and create a very structured guidelines, executable guidelines in the FHIR and secure language, which is, by the way, mandated by, or will be soon mandated by CMS, which is called DROS rule, part of the CMS mandate. So this is the first step. We have the very mature system that allows to define what will be visible to providers. You can define things like whether or not this rule can be set for the auto approval or auto decline, whether you want to do the prior authorization review, things like that. Second is on the runtime, when prior authorization is made, either eligibility or the CRD call, the backend system would have the very complex routing rules. So for example, you may have different vendors. One vendor is doing the radiology, so we would check with that vendor and we will reply back based on the specific code. Or if this code belongs to behavioral health, we can go into another system and ask that system. Providers experience stays kind of separated from that complexity. They don't care what you pair have on the back end. All they need to know is how to get the yes/no response. This is the necessity check and eligibility. Now, when time comes to submitting the form, as I said, we use the standard mechanisms, the standard questionnaire, FHIR questionnaire, and CQL language to interrogate the EMR system. And we also utilize the information about the unstructured data, which is in the EMR. Then when submission happens, if the prior authorization review can be done automatically, we are using the rules which can be configured in the system, or it can go into the backend, into the utilization management system, and somebody at the clinical team would review this and provide the decision. And the decision is sent back into the EMR system. So from the provider perspective, again, it won't be just declined due to the lack of information, which means provider will have to pick up the phone, call the plan, and ask, what is that additional information you need on top of what was provided already? Instead of doing that, and by the way, this is one of the conditions in the CMS rule, one of the items in that rule is that the decline status has to provide enough information for providers to understand why it was declined and how to fix that. So that is kind of comes by default with using the standard. So with the standard, there is a decline reason, which is provided back into the EMR, into the SmartFHIR plugin, and it's displayed back into provider. When time comes for the request for additional information, again, it can go into multiple ways. It can either be just a free-form text, like attach something, or it can be the well-structured. So we have a set of templates like family history, medical history, things like that. So there are a bunch of different templates, which again would go and execute the CQL against the EMR. Everything is designed to speed things up, to reduce the human effort as much as possible, and to make the whole back and forth interaction as fast as possible. And again, when time comes to deliver the final decision, it is done into the EMR system itself. So everything is done. And again, we have both EMR plugin, SmartFHIR plugin, and the payers backend, but we are testing with non-Edifecs EMR plugins, and we are working with utilization management system on the back end who are willing to accept those FHIR bundles. So we are agnostic to what solution will be deployed either on provider or on the payer. And again, this is the beauty of the standard, which makes things different from where they were recently with the specific vendor, proprietary vendor implementations. So to sum up the Edifecs solution, first, direct EMR integration. So we use the standard. Unified provider experience. We try to be agnostic from the provider perspective to what is happening at the back end of the plan. If tomorrow you decide from the plan perspective to introduce one more vendor, for providers, the experience should stay the same. You shouldn't teach them how to go and use that additional portal. They should just click the same button in the EHR system and send the prior auth to you. It is our job from the vendor perspective to route this appropriately and get the response back to provider. CQL usage and FHIR definitely plus. Member friendliness. Many of you have spent a lot of time implementing the patient access API. So now it's time to use it for the prior authorization as well. CMS mandates or will soon mandate that you have to deliver the status to a patient via the patient access API. So that is a piece of the solution. Definitely compliance support for DROS, cost reduction, and scaling with multiple vendors from the UN perspective. The last but not least is prior authorization is kind of the tip of the iceberg, because that same mechanism can be later used to deliver things like gaps in care or HEDIS, quality measures, chart reviews, because first, for those, there are existing standards as part of Da Vinci, which can be used. And second, it is the same interaction between the provider and payer, just a different business domain. So the solution is designed as a future platform to enhance that interaction. To conclude the session today, I just wanted to emphasize a few things or give some advice if you are thinking about prior authorization solution or considering how you should do this. If you're a provider, make sure that your EMR system supports FHIR. If the EMR system does not support FHIR, you may check with your vendor and see if this is in the plans. The ONC supposedly should publish the mandate matching CMS mandate, but for EMR systems, so that EMR vendors would need to implement the FHIR and Smart on FHIR to support the prior authorizations. So that would likely come up anyway sometime next year. The attrition and the cost of the attrition to your business processes. Again, many plans already express this, that they want to take care of their own folks and they don't want them to be overloaded with the routine work. That is something for you to consider. If you stay within the same manual prior authorization, you may lose people. Compliance, we talked a lot about this. Insurance brokers, as I said, now things are changing rapidly. There is a lot of competition in the ACA market, in the just general employer-based market, and the brokers who make the recommendations now look at how technical the plan is. What is the level of automation? Because they want their customers, eventually members, to get all of the benefits. So if you are not following the automation path, then very soon you may be outperformed by your competitors. This goes to the next item, the increased competitive landscape. And last but not least, members can choose. As I said, I, as a member of or patient, I switched my provider because I was not satisfied with the speed with which that provider performed prior authorization. So I can make a choice. Likewise, I can make the choice to change the payer if I'm not satisfied with the quality of the prior authorization. So all these things should push the industry towards the automation, and the automation is the critical factor here. And the last thing is, think about prior authorization as a business problem. So some of the previous mandates were technical. Those mandates were about compliance only or primarily, and it fell under the CIO umbrella or IT umbrella, and they did it. Prior authorization is different. Prior authorization touches a lot of things. Your HR from the attrition perspective, the cost reduction, you can just get a lot of cost reduced by implementing the proper prior authorization. You should also consult with your business counterparts. If you are IT, talk to your business folks at the department, see what they think, what problems they face, and this would help you choose the proper solution for the prior authorization. So prior authorization can be as a cost reduction tool, compliance tool. It can also drive new business to you, as I mentioned, through the brokers who now are members who are now looking at plans with more technically advanced solutions. That's all I have for today. If you would like to learn more, please feel free to visit our website. We have some information out there. We'll be happy to schedule a demo with you if you want to see the solution in action. For the sake of time, I had to only show you some screenshots and explain how solution works in a nutshell, but we'll be happy to set up dedicated time with you and walk you through the solution end to end. With that, we can go into the questions.
Thank you, Maxim. We appreciate it. Any questions in the room for Maxim? Please enter your questions in the chat.
If there are no questions, I can answer some of the questions I received before, which may be interesting to you. One of the questions was, yeah, and feel free to interrupt me if there are any questions from the audience. One of the questions was, what is the level of automation we expect comparing to those 74 to 26% manual versus portals with using the prior authorization. Again, it is a speculation because there is no solution like that in the market being widely used. So all of the estimates are just estimates, but some industry estimations show that the reduction of the manual submissions can go as high as 74 down to 10%. So this is as much as you can leverage by doing the automation. There's a question in the chat about the PA for drugs. The short answer is yes. The solution being standard solution, it is agnostic to what codes you use. We can do the drug automations. In fact, we are doing one of the pilots with one of the blue plans, which includes the drug automations. We participate in the oncology pilot. So we do some pretty complex oncology use cases, general medical, radiology, so pretty much all of the lines of business. There's a question, you mentioned that your medical guidelines change frequency and that you digitize them. How challenging is that to manage? Let me break this into two: how difficult it is to digitize, and then how difficult it is to manage. It is quite easy to manage, but it is quite difficult to digitize, because if even vendors, there are some vendors in the industry, Interqual, MCG, Magellan, and others, which have very mature medical guidelines, and they have systems to manage those guidelines. But those guidelines are not yet fully digitized. So in most of the cases, you will have to deal with the human language format. And the digitizing of that is a difficult task. Luckily for us, we have technology, the NLP-based technology, where we submit that human readable text into some NLP engine, and it produces a structured information and breaks down this into the logical conditions like if, then, else, or choices and so forth. And it also boils this down into specific ICD codes or specific conditions using SNOMED or ICD, which is then being used on the EMR system. So this is a complex problem, the digitizing of the medical guidelines. And I suggest you look at this problem as soon as possible. And the managing itself is not that difficult, although in some examples, we have some larger plans which have very complex routing and complex logic, like if this code, if this is a federal employee, then these policies should be used. Otherwise, use this or that policy, or our own policy or modified policy from one of the vendors, things like that. So there is some complexity. Sometimes it is worth just a special session about the managing of the digitizing and managing of the policies. Let me take the next question. High-level insights of how AI and NLP leverage in prior space. We are using this pretty much all over. I mentioned the digitizing of the medical policies. Second, unstructured documents like the PDFs or progress notes. We have, as I said, some partners who do the voice recognition, which delivers the text version to us. We use NLP to parse these and extract the codes to be used in the prior authorization. On the peer end, decision support, things like gold cards, machine learning to analyze the provider performance, and some prediction analytics, how this, what will be the utilization of this provider in the future. Are you at risk of this provider abusing your system? So it is very widely used. And again, my recommendation would be to explore, if you're looking for the tool, check the maturity of the AI and NLP in that tool, because that is essential and critical for you to do the automation. Next question, can you confirm PA costs? 14 per PA for providers and 10-20 for peers. There is no kind of explicit number, but there are industries provided by WEDI, CAQH. You're welcome to read them. There are different numbers. CAQH shows the number of $10 per prior authorization. WEDI shows a little bigger number. It's not exactly per prior authorization, but there is a 16 hours per week per physician. There is a study by AMA. They also show some costs. So those are estimations. You should understand there is no like fixed cost. And I can tell you that just last night we spoke with one plan, and they said in some cases, single prior authorization costs them $100 if this is a order with multiple prior auths included, and they have to do some escalations. So the cost may really vary. The next question is, based on your experience, how much of clients are interested in these? There has been few firms who have been promoting it by large scale implementations have been nearly to zero. Yeah, last year or 2 years ago, we've done some pilots with Florida Blue and some other providers and vendors. The interest was very, very low. Today, the interest is extremely high. In fact, we're getting requests. We often don't need to reach out to customers. They come to us asking, what is that solution? And the main reason is this is beyond the compliance. If it was just the compliance, probably the interest wasn't that good because the compliance mandate is not yet out. But with the declining economy, all of the organizations are looking at ways to optimize the costs. And prior authorization is the easiest low-hanging fruit to cut that cost, because there is a huge cost and there is an automation, ready automation to cut that cost. So this is one of the reasons why the interest is very high. Can you please speak to total cost to implement specifically for the organization behind the curve on FHIR adoption? So it's again, it really depends on the scale and size. The cost will depend on how many clinical guidelines you'd like to include, because that is one of the cost factor. Second factor would be how many providers can you onboard into the solution. Provider onboarding is a critical piece. You cannot realize your ROI unless you have enough providers participating in this program. And the good news is all of the providers we talk to, they are willing to participate. They just asking to be included. And we've been working on the pilot with one large plan, and they had their friendly provider organization. And suddenly another provider, which was completely unrelated, they reached out to them saying, we've heard that you're doing this pilot. Can we be part of this? Because we need to have this automated. So there are different costs. I don't necessarily answer your question, but feel free to ping me directly. I can give you some additional information and the cost factors. There is no single cost that would fit any organization, unfortunately. Do we need ICD codes for PA of drugs? You may need ICD codes for PA of drugs if the medical guideline requires a certain diagnosis code for this drug to be authorized, in which case you have to have the ICD code providers have to have the ICD code in the EMR system in order to prove that this prescription for this drug is necessary. There are several more questions. Unfortunately, we're running out of time, and I'm being told that we should wrap up. I will ask somebody to provide my direct email in the chat. Please reach out to me, or I will try to reach out to you and answer your question directly. And if anybody has any questions, please use that email in the chat and contact me directly. Otherwise, thank you for your time today. I'm very excited that so many people joined us today, and hope we can continue this dialogue. Thank you.
Maxim, thank you very much. We truly appreciate you and Edifecs. Folks, this concludes our virtual spotlight, automated prior authorization in real time for payers and providers, presented by Edifecs. Thank you for participating.
Thank you. Bye-bye.